I am thrilled to talk to you today about pulmonary rehabilitation, the essential first step in improving your pulmonary fitness. I briefly am going to go over my background and highlight how I'm so fortunate enough to be here with you all today. Like Nydia said, I previously worked in pulmonary rehab for years as a nurse specialist, and that's really what drove my passion for me to go back and get my PhD and research improving outcomes for patients with pulmonary fibrosis through symptom management strategies. And I'm particularly interested in doing this via telehealth to increase accessibility. Oh, and I currently work as an assistant professor at the University of Nevada, Reno. So pulmonary rehabilitation, what is it? I'm sure many of you in this room have heard this word before. I hope maybe a couple of you have even completed a program, but I'm going to tell you a little bit about it today. So pulmonary rehabilitation is a supervised medical program that combines exercise and education to improve the lives of patients with chronic lung disease. Patients with chronic lung disease can attend pulmonary rehab after getting a referral from their provider, and it's really a multidisciplinary and comprehensive intervention that includes 3 components: aerobic exercise, endurance training, strength training, and education. There are numerous benefits to attending pulmonary rehabilitation. It's well documented in the literature that it can improve your dyspnea, which I know you've all been hearing that term a lot this week, but dyspnea means shortness of breath. It can increase your endurance, and it improves your health-related quality of life. Now, how do we know this? When you come to pulmonary rehab, you complete all sorts of pre- and post measures. So when you come in, you'll do something called a 6-minute walk test. I'm sure all of you are familiar with this too. And then you'll complete some self-report measures. And then at the end of the program, we have you do all those things again so that we can compare pre-pulmonary rehab to post-pulmonary rehab and see how you improved. Having worked in pulmonary rehab, I can't tell you how incredible it was to see a patient come in with pulmonary fibrosis and really struggle on that 6-minute walk test, only for that same person at the end of pulmonary rehab to be walking on a treadmill for 30 minutes. So we know there's numerous benefits, but the reality is there are a lot of barriers to accessing a pulmonary rehab program. And I bring this up in the hope that by identifying these barriers, we can talk about strategies to overcome the barriers. Globally, pulmonary rehab is only accessed by less than 3% of patients with chronic lung disease. Less than 3%. That's a huge problem. And so barriers occur at 3 primary levels. The first is referral, the second is uptake, and the third is completion. So looking at the barrier of referral, referral refers to the percent of patients referred to a program. Currently, only 19% of individuals with IPF are referred to a program. And so if you take one thing from my talk today, I hope you take a couple. If you take one thing from it, I hope it's that when you leave here, if you have not attended a pulmonary rehab program, that you are going to go ask your provider for a referral. The second barrier is uptake, which refers to the percent of patients referred who actually end up attending a program. Barriers to the uptake level include lack of perceived benefits. So sometimes patients will get a referral by their provider and they don't actually discuss with them all the awesome benefits that they could get from attending, so the patient doesn't follow through if they get a phone call to come in for that intake appointment. And also travel time. If you have access to a pulmonary rehab program in your state, but say it's an hour away, that's obviously going to present a big barrier. So we are going to talk about some things you can do from home today as well. And then completion refers to the percent of patients who complete about 70% of sessions. And so on average, every pulmonary rehab program is different, but it's typically twice a week for 9 weeks, totaling 18 sessions. So completing 70% of sessions comes out to about 13 out of those 18 sessions. And barriers to this include things like socioeconomic status and disease severity, and currently only there's about 10 to 32% of patients who will start a program who don't end up completing a program. Access to pulmonary rehab, these are the different stages. So let's say that you get referred, and we kind of want to talk about what stages you will go through with the pulmonary rehab program. So stage 1, first and foremost, is referral. So you have to get that referral from your provider. Stage 2 is the intake appointment. So you'll actually go to the pulmonary rehab facility and you'll meet with a healthcare provider and they will do your intake assessment. So things like 6-minute walk test, they'll have you fill out those pre-survey forms. And then stage 3 is where you actually attend the bi-weekly sessions. And stage 4 is always very exciting. It's your final session, graduation day. And you can find a program by going to this website here, aacvpr.org/program-directory. And by going to this website, it will give you a list of accredited programs through the AACVPR, which is the American Association of Cardiovascular and Pulmonary Rehab. And it will give you a list and you can see if there's hopefully a program near you. What will you do during a pulmonary rehab session? So there's 3 components to pulmonary rehab: aerobic exercise, strength training, and endurance. With aerobic exercise, it's important for you to know that the pulmonary rehab team will meet you where you are at. There are so many different ways to participate in aerobic exercise. We have recumbent bikes, we have stationary bikes, we have treadmills. Sometimes a patient can be so deconditioned when they first come in that we start them seated in a chair with an arm bike. And that's great. We'll work our way up from there. So don't ever be inhibited by the fear that you aren't able to participate in the aerobic exercise, because there are a lot of variable activities that we can do, and the PR team will find the most curated, well-suited plan for you. Strength training encompasses handheld weights varying in size. And then education, there's a lot of great educational topics that you'll learn about, things like breathing exercises, which I am going to talk about briefly today, nutrition. It's all very important, pertinent for you. Let's say that you are unable to attend a pulmonary rehab program due to insurance coverage, lack of access to a nearby program. The good news is that virtual pulmonary rehab has been demonstrated to be equivalent to in-person pulmonary rehab at reducing symptoms of breathlessness and increasing 6-minute walking distance. So this was by a recent study, and the PFF Pulmonary Rehabilitation Toolkit is on the PFF website, and this is an excellent resource for you. If you go to the PFF website and type in Pulmonary Rehab Toolkit, it will come up. There's 8 modules, videos, readings, and it's asynchronous, meaning you can work through it at your own pace. And it's essentially going to be like completing a pulmonary rehab from the comfort of your own home. The other thing that you can do right now, and I highly encourage everyone to start doing today, is daily breathing exercises. Breathing techniques or breathing exercises can reduce your perceived dyspnea. Now, there's 2 main types of breathing exercises that we teach in pulmonary rehab, and I am going to go over those. But before I do that, I want everybody right now to take a nice deep breath in and exhale. Okay, so when you did that, I saw it in a couple of people. Did you feel like when you took a breath in, you got a little bit taller in your chair and your kind of shoulders raised up a little bit? If you're nodding yes, I hate to tell you this, but you're breathing wrong. So our one true muscle of respiration is called our diaphragm. And our diaphragm sits here between our chest and our abdominal cavities. Everyone in this room is born knowing how to use our diaphragm to breathe for us. You'll hear the term diaphragmatic or belly breathing. Those are interchangeable terms, and this is what I'm talking about. We're all born knowing how to belly breathe. Think of a baby lying in their crib at night, and they're sleeping, And what are they doing? Belly rise, belly fall. Belly rise, belly fall. It's because they're belly breathing. Well, somewhere around the age of 6, 7, we go to school. We're sitting a lot. We get older. We're sitting in our desk working a lot. And what do? We start to incorporate all these extra accessory muscles in our neck and shoulders to help us breathe. These are not meant for breathing. So the next time that you have some neck and shoulder pain, you might want to check in with how you're breathing. So what can we do about this? Breathing exercises have been shown to be effectively learned in 4 weeks when practiced daily for 10 minutes a day. This is per the American Lung Association. 10 minutes a day. So there's 2 main types that we're going to learn about. The first is pursed lip breathing. I want you to remember to smell the roses and blow out the candles. Pursed lip breathing is very simple, helps you reduce dyspnea, and also helps raise your oxygen saturation. So you breathe in for 2 seconds through your nose, and you exhale through pursed lips as if you're blowing out a candle for about 4 seconds. And you can practice this anytime, anywhere. Now, diaphragmatic breathing is just pursed lip breathing plus 1 extra component. And that extra component is that now we are paying particular attention to what our diaphragm is doing. So when we breathe in through our nose, our lungs are going to fill with air and push our diaphragm down, which results in our abdomen filling up like a balloon and coming out. Then when we exhale through our pursed lips, our belly returns back to a comfortable resting position. The best way to practice this is having 1 hand on your chest and 1 hand on your abdomen. You want to make sure that the hand on your chest is not moving. The hand on your abdomen should be the one doing all the moving. The other great way to practice this is lying flat in your bed at night, because it really forces you to engage your diaphragm to breathe for you and let go of those extra accessory muscles in your neck and shoulder. I will say I just ran a breathing exercise study via telehealth where we implemented these breathing techniques over the course of 4 weeks. And the coughing that starts when you begin to practice this is very common. It is so common. And most of my patients reported, my daily 10-minute sessions, I really was coughing in those first 3 minutes. But then I noticed that it went away and it actually improved my cough throughout the day. So let's do a quick practice session here really quick. So we're going to breathe in through our nose, and our belly is going to fill up with air. Well, our lungs fill up with air, and our belly comes out. And then we exhale through pursed lips, and our belly returns to a comfortable resting position. Like I said, 2 most important things. Hand on the chest should not move. Hand on your abdomen should be the one doing all the movement. And tonight when you go to bed lying flat, it's a great way to practice this. In summary, pulmonary rehab is the essential first step in improving pulmonary fitness. You can ask your provider for a referral to a pulmonary rehabilitation program near you. And if for some reason you are unable to attend a pulmonary rehab program, let's say, for example, there's no nearby program or you don't have insurance coverage, then you can use the PFF Pulmonary Rehabilitation Toolkit from home, as well as starting to practice those daily 10-minute practice sessions, because they really do help you learn how to manage your shortness of breath and improve your oxygen saturation when you are feeling short of breath. This is my contact information here, my email, LinkedIn. You can follow me on Instagram at Breathe with Aubrey. Like I said, I do a lot of research with breathing exercises and specifically delivering interventions via telehealth for the pulmonary fibrosis community, because I think telehealth is really going to be the way of the future. COVID did a lot of bad things, but if it taught us anything, it's that there's a lot of power in connecting people via telehealth. Thank you all very much for your time today, and I look forward to any questions.
Hi, everybody. It's great to see so many people here. Sometimes I'm a little animated, my throat gets a little raw, so please bear with me. I'm Renee. I run the diagnostic labs for Rush University Medical Center in Chicago. I've been doing PFTs for a long time, so I'm the one who screams and yells at everybody and Everybody will say, oh, my sister had that test, it was horrible. It all depends on their experience, and it all depends on their condition as to how well they have it. Other people will say, oh, I had that test and it was nothing, and then someone comes in and they struggle to perform this test, and they go home feeling as if they failed. Nobody fails this test. These are your numbers, and that's what we're looking at. So what do all these numbers mean? When you go to have a PFT, there's this long sheet with tons of information, and everybody says, there's all these numbers. You don't really know what they mean. You don't know what the doctor says. Your doctor will talk to you and go, oh, your percent of predicted is this much and that much, and then you walk out and you have no idea what they told you because there's so much information during this visit. So I'm going to try to break this down for you, and at the end of this presentation, my email address is on there. If you have any questions, please feel free to contact me. I'm happy to work with anybody, answer any questions you may have. Okay. So what we're going to cover is actually understanding pulmonary fibrosis, which most of you probably have an understanding or a brief understanding. I'm going to do a very generic explanation of all of these things because there's lots of information related to this. And if you need more information, please reach out. I'm going to define what is involved in a pulmonary function test known as a PFT. You're going to evaluate the results of spirometry, lung volumes, and diffusion tests, which are also referred to as DLCO. So when your doctor orders a complete pulmonary function test, that's what you get: spirometry, lung volumes, and diffusion testing. A lot of people get paranoid and panic when we do the lung volumes because we put you in a box and we shut the door. It's an airtight box. Nobody likes that, myself included. We're going to discuss the changes that occur over time and then just an overview of the results for you, okay? Excuse me. So again, pulmonary fibrosis, this is the short version because as you guys know from being here, there's lots of information related to pulmonary fibrosis, the disease process, the medication. So as a respiratory therapist and working with a lot of patients with pulmonary fibrosis, it's permanent changes in your airway. The lung tissue does not regenerate, it does not heal itself. So once there's scar tissue and there's destruction, you always have destruction. So you get shortness of breath due to the lungs becoming stiff. The stiffer your lungs become, the less they can expand. Like you can take this nice deep breath and over time it's less and less and less. So what we do is we track that volume and we look at how much loss you have over time. And they can calculate, based on the rate that you're losing volume, how much time you actually have before you are in trouble or in need of a lung transplant. Does that make sense? So a PFT is a series of specifically performed tests. And I'm a huge advocate for making sure that you get your testing done in an accredited facility. You want to make sure that the equipment they use is good equipment. You want to make sure that there's good physicians, quality physicians reading those tests, and that the people performing your test are trained in that area. Anybody can go in and yell at someone to do spirometry, but not everybody has the ability to get that test out of a difficult patient or has the ability to understand what they're looking at to know if those numbers are valid or not. So I'm really good at yelling at people. So how do you get a PFT? You can't just walk into my lab and say, gee, I want a test. You have to have a physician order. So your physician or your care team can have one. And if anybody here has not had a complete pulmonary function test, go back to your physician and request one because you want to have those numbers to track along with all of your symptoms and how you're feeling over time. So and as I said, it should always be performed by a healthcare professional. And as a patient, you have the right to get your test results with the physician interpretation on it once they've been finalized. Then you can track your own results and kind of be your own advocate over time. So normal lungs, okay? So if you have normal lungs, your average population, nothing's going on, all of your values are going to be normal. You're going to have normal spirometry, you're going to have normal lung volumes, you're going to have normal DLCO. Well, who determines what's abnormal? So if you have pulmonary fibrosis, you're going to have difficulty when you lay flat. You have a lot of trouble breathing when you're laying flat, or if you're climbing stairs, you start to notice it early on. You have a lot of coughing. A lot of times they'll say, oh, take some albuterol, go away, come back later. So if you feel that you're still having shortness of breath, you're still having trouble, or a family member does, send them to go get testing to find out what is going on. And we like to monitor everyone closely for any changes going on. So if you already have pulmonary fibrosis and you've gotten your PFT test and you happen to notice you had a bad cold, you can't breathe as well, you can't walk as far, you're having trouble going up the stairs, talk to your physician. You may need to have another test just to see if your volumes have changed. So understanding all these numbers, and there are a lot of numbers with this. So, sorry. So now I have to kind of take you guys backwards before we can go forward. So there's reference values that are used to compare numbers. So everybody in here is going to have a different set of values. So if you know, my friend Joan says, oh, I had a PFT and I was totally normal, but Joan's 5'11", you know, and I'm 5'5", my values are going to be different than hers, you know, and based on your ethnicity, your age, your height, and your birth date, there is a predicted set of values out there that they compare your numbers to. So they took 5,000 people in each subgroup and figured out what was normal for African American, for Mexican American, for Caucasian people. And then they plugged all those numbers in, and based on your age, your height, and your ethnicity, they determined where your numbers fall into their normals. So there's something called the lower limit of normal. It's a huge range. And then if your numbers are below the lower limit of normal, then they look and see, okay, there's something wrong, you're out. 5% of the general public are still going to be out of that 5% of normal. So if your numbers are on the low end of normal, you just keep an eye on them. You just want to see what's happening, but you can track your own numbers over time. And it's very important for you to be advocates for yourself to know what those numbers are, to know if you're getting worse when you have a cough. If they put you on a different medication, are your numbers improving? Are your numbers getting worse? Are your symptoms improving? Are your symptoms getting worse? You kind of want to keep a journal and keep track of all of that. So what is a PFT? This one I could go on for like weeks for you, but you guys would kick me out. Spirometry is the most common test out there. Any allergy office, pretty much everywhere you go, they can perform spirometry. Spirometry can diagnose an obstructive illness. It cannot diagnose interstitial lung disease or pulmonary fibrosis. It can suggest restriction, and then you need to get a complete pulmonary function test. You need to have lung volumes to have an absolute diagnosis. And then again, it just repeats. A complete pulmonary function test, sometimes your doctor will order it and it'll say CPFT. That's a complete pulmonary function test, which includes spirometry. Usually they'll do pre and post bronchodilator for you. They'll give you medication. If you're an asthmatic or have COPD, you'll respond to that medication. Generally with pulmonary fibrosis, you don't respond to that medication. They'll do lung volumes on you, and then they'll get your diffusion. So they look at all of those variables to see what's normal and what's not. So once you've had a complete pulmonary function test, they can track your vital capacity by doing the spirometry test. You can go like every 6 months or every year and have that if you don't want to have the complete test. It takes approximately an hour, anywhere 45 minutes for an hour, and it is patient dependent. So somebody has to be able to follow the commands, take the nice big deep breath, blast it out as hard as you can. We put you in a box, we cut off all your air, we tell you pant back and forth, we give you gas. Yeah, I see someone like, a lot of people, but you have to be able to complete the test, and my job is to make your experience the best possible one out there because you have to have this test. I want to get good, reliable data out of you to give to your doctor, and I don't want you to have a miserable time there. So, some of you may have seen this, some of you may have not. This is called the body plethysmograph. So this is when you're doing lung volumes, the patient is inside that box, the door is closed, it's an airtight cabin. We know based on your age or based on your height, how much and your weight, how much volume you take up inside that box, and we can calculate for the air that's surrounding you. That's kind of the short version of this. So it generates images of the values that you're calculating. It kind of gives the doctors an idea if you have obstructive disease when you're breathing, if it's restricted based on the tangents that these lines produce, which is like respiratory class 69, so or 68, so that you guys don't need to worry about that. But what you want to know is when you go for a complete pulmonary function test, if you are on oxygen, we need to take your oxygen off when we close the door and do that portion of your test. We monitor you, we're used to doing this. It's very safe. The door is actually only closed for about 2 minutes. And then you can come back off. If you're very short of breath, you can put your oxygen on and off in between all of these maneuvers. So I like to kind of ease everybody's anxiety. When you get this test, a lot of people think, oh, I'm going to fail. I won't be able to do it. Just take your time, relax. You're going to breathe for us. We're just going to make you breathe hard, fast, slow, deep, a little at a time, okay? So what your vital capacity is it's the maximum amount of air that your lungs are able to pull in. So when you take that really big, deep breath in and fill all the way up, and you exhale that volume all the way out, there's still a certain amount of air left in your lungs. That amount of air that's left in your lungs is what we're able to get with that body plethysmograph. But your vital capacity is that deep breath in to all the way exhaled, and that's a number that you can track on your own as you're going. You'll get that vital capacity number from the report, keep track of that, and see if it's dropping over time. Excuse me. So what we usually do is we compare the forced vital capacity to the fraction of exhaled volume in that first second. It's called your FEV1, and this is how we can diagnose if there's obstruction. You take that big breath in, you blast it out as hard and as fast as you can. We compare the overall amount divided by that first second amount and see what the ratio is. Generally, with pulmonary fibrosis, your ratio is high. Everything looks normal. What we're looking at is on the far end, we're looking at the percent of predicted for your forced vital capacity and for your FEV1. Generally, that will be at about 60%, 60 to 65%. That tells us there's a potential for restriction. I can't look at you and say you have restrictive disease. I need the rest of the test data. So lung volumes. Lung volumes looks at all of the air inside the chest. It looks at the whole thing. It has to be done in a pulmonary function lab. It's that body box connected to a computer. You have a technician there guiding you with testing that you need to do. As I said, the door is closed for about 2 minutes while they get that value. You don't really feel anything, but you can't have your oxygen or anything else inside the cabin with you when you do it. Everything can be right out. So in pulmonary fibrosis, the airways and the lung sacs tend to get stiff and hard. There's a lot of destruction going on in the airways. So a lot of times on a CT scan, your lungs have like a honeycomb appearance. And when you get that honeycomb appearance, they're not participating with gas exchange. So you have shortness of breath, you have a lot more difficulty. Over time, the destruction actually becomes a lot worse. So the values that we get for your pulmonary function test and your CT scans are compared to the first ones you get, or before, if you ever happen to have them just for general health purposes, those numbers will track all along your whole life. So they'll go back and they'll look, here was your CT scan, here's one at 3 years, 5 years, 10 years down the road, gives you all the information that you need. Okay? The decrease in your volume in your lung volume numbers are related to they predict your mortality. So based on how fast they're dropping or how low they are, it gives the physicians an indicator. You know, if you get a cold, you get sick, you get COVID, things are always worse. But people go for a long time. There's a lot of resilience, and exercise is a huge tool to keep you alive and keep you happy. Okay? So this is a CT scans. The one on your left is a normal CT scan. The one on the right is pulmonary fibrosis. So it kind of gives you an idea of what actually happens inside your lungs and how difficult it is for those lungs to expand and contract when that's going on. So it's kind of scary. Okay, so PFT results. So now that I gave you all this information, basically now it's, testing time. Just kidding. So the reference limit. So as I was saying earlier, we look at the lower limit of normal. Some people look directly at the percent of predicteds. We look at the lower limit of normal. That's the universal thing across the country. So if you're in a good accredited PFT lab, you should have the same test results in California as you have in Florida, as you have in Europe. Everybody is using the same standards. So we try to make sure that everybody's on the same page. So nationally, the American Thoracic Society uses the lower limit of normal to determine if you're normal or if you're abnormal. And they look at every section of that test. They go through the lung volume section to see what's out of range, what's not, if there's air trapping. They look at the diffusion, diffusion looks at how well the gas you breathe in actually diffuses through the lung tissue and gets into your bloodstream, and how well your carbon dioxide comes out of the blood and back out into the room. So you get a lot of information with one pulmonary function test. Okay, I don't know if you guys can quite see this, but this particular test, the very top box, is the spirometry numbers. The first box where it says pre, that was the patient's values. So their forced vital capacity was 2.7 liters. The lower limit of normal is 2.0, so he's above the lower limit of normal, he or she. The FEV1, the fraction of exhaled volume in the first second, is 2.10, and then the lower limit of normal is 1.42, so those look normal, right? So if you look at the ratio, the FEV1 to FVC ratio is 78%. That would be considered normal. So if you just had spirometry somewhere, you'd go on your way and think, hey, everything's good, there's nothing going on. So again, I can't diagnose restriction with just spirometry. But if I send you for the complete test, then we move along and we look at the lung volumes. The TLC is your total lung capacity. So when that box is closed and they get all of those values, your TLC is something you want to track. The TLC, the lower limit of normal, is 4.55. The patient's value is 3.79. So that patient is well below the lower limit of normal, so it's a red flag. Something's going on, why are we reduced? If I had COPD or hyperinflated, those numbers would be larger than normal. So if you look at the vital capacity number, it still says it's within the normal range because the lower limit of normal is 2, and we saw our vital capacity from the top part. When you look at the pleth, the FRC pleth, which is where we got those actual lung volumes, the lower limit of normal is 2.45, and they're at 2.37, so it looks normal. So when you look at the lung volume section, there's a lot of information. You want to track the TLC. Is your total lung capacity going down? This particular one is at 66%. So that would flag a doctor, even if it's a regular general practitioner, and say, hey, this might be restrictive disease. They need to look at it. The next thing we do is we look down at the diffusion testing. So normal diffusion testing on this one should be 3.06. This is 1.7, so 1.79. So this person is 58%. So their gas is only exchanging 58% of the values that it should be exchanging. So that kind of overall picture lets you know there's some kind of a restrictive thing going on. The lungs can't fully expand, the gases can't exchange, and they can't contract. Does this make a little sense? So we monitor these and we track these because you'll go to the doctor and you'll get this report. So remember, track your forced vital capacity, track your FEV1, track the ratio, FEV1 to FVC ratio, look at your TLC, look at your DLCO single breath number. Single breath is the type of test that it is, but that one will give you a good indicator of what's going on. So this particular patient, we trended over time. In 2015, the vital capacity was 3.32, the TLC was 4.84, diffusion was at 15. 6 years later, in 2021, we were at 2.88 for the forced vital capacity, 4.37 for the TLC, and we were at 9.9 on our diffusion. So you can see kind of a significant drop there. So the patient was doing okay, didn't go to the doctor for about 5 years, wasn't feeling well, went back in, had all the tests done, but then within a year's time, they dropped again. From 21 to 22, his vital capacity went from 2.88 to 2.70. That's 180 mLs that patient lost in 1 year. Doesn't seem like much, but it is. His total lung capacity went from 484 to 379, so he's lost an entire liter of air there, and his diffusion is down to 8.75. So that's kind of why you want to track and trend those values for yourself. Exercise does help to improve these numbers, help sustain a longer activity. So it really is very important, but it's really important for everyone to be their own advocate, to know what your numbers are and to know what they mean. Don't count on somebody saying, oh, you had a test, and then nobody gets back to you. We know, being in medicine, the ideal picture is somebody gets your test results and they call you right away, but the reality is they get your test results, they get 50 other tests, and then you don't find out what your results were for 6 months later, or you keep going for test after test trying to figure out what's wrong. So you kind of have to bug people to get your results. But it's really important if you know what your results mean. Okay, these are the references I used. The American Thoracic Society is a great reference. You can go to ATS or to CHEST and just type in pulmonary function testing, and you can get lots of information. And then there's my email address. I'm happy to answer any questions anybody may have, and thank you.
And so I'm going to talk about functional fitness as a lifestyle. And yeah, it was true that I was an Ironman triathlete, and at the age of 62, January 18, 2020, everybody remembers 2020? I was January 18 on my birthday. I got up that morning and I swam about 1,000 meters in a pool, And after that, I ran probably 4 or 5 miles at a fast clip. And I probably walked about 15,000 steps that day with my dogs. And just living downtown Tampa, I was very active. And January 20th, I woke up and I was sick. I never got sick. I'd always been very healthy. And I felt very bad. January 20th, I couldn't figure out what was wrong with me. Here's what I did before. There's pictures of me about to swim in the Irish Sea, jumping into an ocean where I swam 2.5 miles. Took an hour and 40 minutes to swim that distance, but that was at the age of 50, early 50s. But at the age of 62, I could still do these things. I'm finishing the Ironman of Florida after racing for 13 hours and 9 minutes. Constant racing for 13 hours and 9 minutes without oxygen or anything like that. But suddenly I was very sick, and I couldn't figure out what it was. I recovered after a few days, and then started back swimming, but something was not right. And as 2020 moved on, talked to my doctor, and she said, you may have had COVID, but it's too late now to test, and there are no antibody tests yet, so we don't know whether you had that. I developed pneumonia, went to the ER, they did x-rays, looked at it and said, yes, you have pneumonia. I went back home and people on my conference call started telling me my lips were blue. And they said, you're coughing all the time. So I got a spirometer, and I realized my oxygen level, when I was moving around, were in the low 80s. And so I was starting to get in trouble. I went back to the hospital again, to the ER, and this time they said, the diagnosis wasn't quite a medical diagnosis. The doctor said, your lungs are a mess. They looked like that lung up there, except on the grayscale of it. Anyway, so I was referred to as a pulmonologist, and I went to that pulmonologist, and they take a look at the 6-minute walk test and saw how quickly I desaturated. So they ordered up some of these CT scans and some pulmonary function testing, and these are excerpts from that. But there I go from being an Ironman triathlete to suddenly I read this report, and it says I have ground glass opacities and honeycombing scarring and traction bronchiectasis, lung distortion. My lung was distorted, architectural distorted. It was deformed from the scarring, and volume loss, massive volume loss. And the findings, I underlined that in red. I read that, I said, end stage, pulmonary interstitial. Holy cow. That was a blow. And as a result of that, they sent me home with oxygen, recommendation for an open surgical biopsy to figure out what the cause of the IPF was, but I didn't want to go with the surgical biopsy. At that time, the hospitals were kind of full of COVID, and the system was, I just didn't want to go in to do that. So I dove off the cliff, and I call this 11 months in the valley of despair. And so I go home with my oxygen. I'm living in downtown Sarasota, and among all the beautiful people of Florida, And suddenly I'm the old guy pushing the oxygen tank, like, holy cow. And I was ashamed, oxygen shame. Anybody ever had oxygen shame? It's like you didn't want to go out in public with that. So I became the guy in the recliner, ordered everything on Instacart and Uber Eats, and sat there. If I could leave the door unlocked, they'd deliver it to me in my recliner. And I spent the year of 2021 slowly declining and declining, planning my end of life, because I believed that diagnosis at end stage. I got that 3 to 5 year that Google tells me I've got left, So I got a lot of anxiety, a lot of depression with that, and claustrophobia. So I was too weak to even walk downstairs or upstairs where I lived. I was on the 4th floor, and I was too claustrophobic to get in the elevator. So it was a miserable time. I hired dog walkers to walk my dogs for me. I became extremely sedentary, and as a result, I lost muscle, I lost conditioning. I went from 185 pounds, very fit, to 150 pounds. I look emaciated. There's a concept, I've developed applications for insurance companies on injuries and how to help people recover for injuries for workers' comp and disability claims. And so I understand a lot about recovery. And there's a concept of 3 to 1. For every 1 week of bed rest, it takes about 3 weeks to recover. okay? And so I had 11 months. I needed 33 months to recover. So it was, ahead of me was a tough time. Also, by being so sedentary, I ended up with pulmonary embolisms. I had 2 blood clots that we had to resolve with medication. So I was faced at this time of darkness with a life choice. And, I had this blind guy walking across the street, and I sort of equated it to that. I had begun meditating and resuming a good long-term meditation practice and thinking about where do I go? How do I get a vision for healing and health and recovery and getting back to some sort of normalcy in my life? And I thought about if I were to be diagnosed or suddenly go blind. If I went blind, I'd have a choice. I could stay home and hope for someone going to find me a magic cure for blindness, and I could sit home and just isolate in my blindness. And basically, my lungs were my blindness. I was sitting home with that and just declining. So I said, okay, if a blind person goes blind, they can choose to, well, they'll naturally develop the better hearing, better tactile senses, better smell. So a person can develop those skills and be able to move around and have a good life. And I said, well, how do I apply that to my lungs if my lungs are my blindness? So I took a systematic approach like I designed systems before, and I said, okay, there are 5 aspects of my quality of life. And my lungs are my blindness. There's, we've talked about DLCO numbers, the diffusion capacity. Mine's 32%. We talked about what my PFT showed, that my lung function is about 28% of normal. Okay, so it was, I went really down very far there. But so my lungs were very handicapped there. But what could I do with my mobility to build strength, to be able to move, develop muscles like Aubrey talked about? The skeletal muscles are so critical for metabolic things and to keep us balanced and able to move around and to more efficiently use oxygen. So I thought about, how do I develop that? How do I get better mental balance? Get rid of this depression and anxiety through meditation, not through medication, meditation, not medication. At the base of all that, I've seen a lot of people die of heart disease. My father died of a heart attack with IPF. He had IPF, but he died of a heart attack. And people die of all sorts of causes. Heart disease is a major, number one in America today. So how could I strengthen my heart? And so in support of all this, I had to have high quality nutrition. So I set about building a plan. I may have pressed the wrong button. I set about building a plan and began my long, slow journey back, okay? I started slowly with increased walking. And so the pictures, don't let those fool you. Just because the early pictures were me of racing an Ironman, I was as weak as you possibly. I couldn't walk to that door back there on 6 liters of oxygen without help. I mean, I was that bad. So started trying to get 1,000 steps a day, 1,500, gradually tracking that and slowly increasing that. I added the lung and diaphragmatic breathing exercises, okay, critical. That's not just for pulmonary rehab. That's not twice a week. That's every day. For the last 2 years, twice a day, every day. I've never missed. I'd sooner not brush my teeth than miss my lung exercises and my breathing exercises. They're critical. And you'll see in a minute what they've done to help me maintain my pulmonary function. So I also began pulmonary rehab. I couldn't find a local one that worked for me, so I did some online pulmonary rehab, and I learned a lot. Pulmonary rehab is a safe space where you can learn what your limits are and learn how to monitor your limits so that you can continue that, because pulmonary rehab is not twice a week. It's not once a week. It's every day. You know, for us to live and have an effective life, have an enjoyable life, it is. I graduated in strength training with simple ways, stretch cords, things like that. And supplemental oxygen is my superpower. The bottom, these are just some photos I put in a little photo collage. The bottom right-hand corner is me in the gym. I work in a big gym, Crunch Fitness in Sarasota area. And, it's full of big muscular guys and tattoos and beautiful women. And I'm the only old guy with an oxygen tank. Never seen anybody else with an oxygen tank in the gym. But there I am. I'm doing box jumps, which is a 24 or 30-inch box from a standing still, jumping on top of it with an oxygen tank on my back. I do pull-ups with an oxygen tank on my back. I swim in the pool, and I keep my tank on the side of the pool, and every 2 laps I stop, I rehydrate, reoxygenate, and swim another couple of laps. I'm running on the beach. I do archery. I do stand-up paddleboarding with an oxygen tank. I wear it over my life vest. I have to have a large life vest to float me and a tank. I hate having to go to the gym every day of the week. I go to the gym a couple times a week for some strength training, but bottom left-hand corner, you can't really see that very well, but that's a home gym right there. I've had nice home gyms before, but this one, there's 2-gallon jugs of water. 8.3 pounds is a gallon of water. You do all kinds of great work with 8-pound weights that have nice handles. There's a sandbag, there's a cement block, and a stretch cord there. The cement block gets me some looks from my neighbors sometimes. A cement block weighs 35 pounds, and I do something called block around the block. I take my block for a walk around the block, and I carry it. I carry it in one hand, I switch hands. So that's called the farmer's carry, and it's a great stability builder, and it will rev your heart rate up. And invariably, at least twice on every walk around the block, somebody stops and says, they see a guy with an oxygen tank and a cement block, and they say, "Sir, can I help you?" and typically, they're in a golf cart, which everybody in Florida gets a golf cart, so they don't have to walk the half block to the pool. So anyway, I exercise daily for functional strength, for things that give me the ability to get down and get up and move around, that sort of thing, not to be a muscle man. And I won't race Ironman again, I doubt. But another thing I've done is I thought I was going to go into hospice at one point. And so at a point in time, I said, I want to volunteer, do something to kind of get out of myself, focus on, how my PFTs, how's my blood oxygen. So I got trained for hospice, and I work with hospice patients in the hospice house in Bradenton, and do some Reiki work with a number of patients, and I get to see people in a lot of situations that give me a lot of gratitude, and it's real special to be able to do that, and it's helped me immensely. I've resumed a healthy lifestyle. I mean, you see the kind of things I do: hiking, paddleboarding, weightlifting. I play golf, I play pickleball, and I do it all with an oxygen tank, and I'm proud of my oxygen tank. Somebody in the gym once asked me, "Where'd you get that?" I'm like, you got to get a disease to get that. On the sidelines of the NFL games, what do the big linemen do between they're out of breath? They pop the oxygen mask on. So people in the gym thought I had some secret to getting those things. So critical for me. Look, these things are cheap. Tracking devices are cheap. And we spend all kind of money on all kind of stuff. If you've got pulmonary fibrosis, and if you're in pulmonary rehab, encourage your patients to get some sort of tracking device. This thing I love being able to know what I've done and what I've done each day. The fact that yesterday I walked 17,000 steps, I want to know that. I want to know what my heart rate is. And I use the Apple Watch, and this is the Heart Watch app. But I can look back on this, and it tells me what was my day. This was Sunday. My average heart rate during exercise was 98. Okay, I had 7 minutes in very high intensity, which is about 85% of heart rate, and I trained it to rev my heart rate up. As any exercise physiologist will tell you, when you get your heart rate up into that zone, and I'll keep it up there for only about 10 to 14 minutes, and then the rest of the time is at a good level of aerobic threshold working out, like 40 minutes that day in fat burning. So it gives me this historic view to look at each day. I can see that Saturday I had kind of a light workout day, and last Thursday it was 103 was the average. So those things are they're motivational. I love seeing that data. I mean, first thing when I wake up in the morning, I check what's my sleep score? How did I sleep? And I measure my blood oxygen level, my heart rate variability, my sleeping heart rate, how many sleep disruptions, because sleep is critical for us to recover. So it allows you to be accountable and fine-tune your exercise. Also, it gives you kind of a look back at the past to say, okay, over 6 weeks, I spent 41% of my exercise time walking, and a fourth of it was in high-intensity exercise training, carrying blocks around the block, that sort of thing. But I also have a good variety. Tai Chi, hiking, rowing, and then there's the other category, which may be archery or anything like that. But I just love that. I've got a couple last slides, and I've got zeros, so it means I'm out of time, but tough. This is a view from my tracker of my heart, of my workouts. Prior, in 2019, I had 97 minutes per day of exercise. I fell off the cliff. And I don't know how, after reviewing this slide 200 times, I spelled despair wrong. Okay? And I never caught it. Even the red squiggly line under it, I never caught the fact that I spelled despair wrong. Why didn't we catch that? Anyways, but in 2021, I averaged 11 minutes, from 98 to 11 minutes. Okay? And then now I'm back at 98 minutes a day in exercise. And what's the result? Here's the result. My walking heart rate in 2021 was 115 beats per minute. I used to run a marathon at that level. And that was just walking with an oxygen tank, 115 beats per minute. After exercising for 2 years, it's 84. Huge increase, about 27% improvement. And that walking score is without oxygen. 4 miles a day, walk my dogs without oxygen. My resting heart rate used to be 75 in the worst time, and now it's 51. It wasn't that. It was, the last time it was out, I was probably 48 years old, 50 years old. And there's no, I don't take any medications. I don't take any prescription drugs. Everything I do is kind of natural. You know, if you're from pharmaceuticals, I think it's great. Esprit, OFEV, all the different things, they're fine. But what I do can supplement and make them more effective, I believe. In 3 years with advanced IPF, a 31% DILCO, 28% lung function. This is a graph of my spirometry. Both I do spirometry and I also go through the full, I've had the full test and the DILCO and all that done, but I've also lost no lung function in 2 years. I've actually had some improvement in lung function and lung volume. I attribute that to the lung exercises that I do. And so all these things, they support a medical treatment. They support your medical treatment strategy, if you're going for a lung transplant. I've got friends who have had transplants. They were in good shape. They went in. They were exercising. They went in. They had a lung transplant. They came out very strong, and they're doing very well because they've taken care of these other factors other than their lungs. And in summary, proper breathing, lung muscle exercise, functional daily whole body exercise, and train for the heart rate. That's key. Sleep quality and quantity, and then mindset, beliefs, and vision. The things we do to continue to live and enjoy life are hard, and that's the what. And I've always been told that the why has got to be bigger than the what. So finding purpose in our life, Pulmonary Fibrosis Foundation helps to give me purpose. Working with facilitating sport groups, helping other folks who are wandering around lost in the wilderness, wondering, holy cow, I just got this disease. What do I do next? That gives us purpose, all of us. And this is the last. I'll close with a quote sort of from me. I borrowed the first part. Life's 10% what happens to you, and 90% how you respond to that, right? I had become weak, unhealthy, and depressed, but that was not caused by pulmonary fibrosis. That was simply my reaction to pulmonary fibrosis. When I chose to change my response, my life changed dramatically, and pulmonary fibrosis could not and cannot stop me from enjoying my life. So thank you all for your time.